you come along and bingo.
My name is Lisa Pine. I'm a physical therapist here at UC Davis Medical Center. I work inpatient, so I'm an acute care physical therapist. And acute care physical therapists are generally treating their patients in their rooms in the hospital or just outside their rooms. So we work with patients early on in their recovery, oftentimes with very sick or very debilitated patients. And so we start working with patients sometimes when they're not even able to get up and out of the bed just yet, up to and through the point where they are able to, in some cases, ambulate on their own. This is a cardiac chair. It's kind of a giant, oversized chair that can be in either the position of a chair, but it also can move down into the position of a gurney. What we would do is with the patient here in the bed, we would pull the patient over onto the cardiac chair. And then we would bring the chair up into an upright position once the patient was secured, like so. So the problem with that is that you can see when a patient is lying over the sheet, it creates a tremendous amount of friction for the employees who are involved in moving the patient over. So if there was a portion here, say this portion slid over, that portion slid over, but then what we could do would be to roll. So I'm going to have her do it on her own, but if it was someone who needed help, we could help them roll. This piece could slide across underneath them and then roll back on top of it and then slide the person back over onto the chair. And if that was integrated into the chair itself, it would lead to much better, I think, use by staff versus them trying to go find some other piece of equipment to help them transfer a patient over to the chair. So another issue with a cardiac chair, and that is we also use this cardiac chair once the patient is in the chair. We work on them being able to stand up and sit down. So as you can see, the angle between the seat surface and the leg rest doesn't even come all the way down to form a 90-degree angle. The angle's a little bit obtuse, so to try to expect someone who's weak, debilitated, or has maybe a weight-bearing limitation because of a fracture or surgery, to ask them to try to stand up from that surface when they can't get their legs underneath them all the way. So it's a little bit hard even for someone who's perfectly healthy, let alone someone who's having difficulties. So an improved feature would be to have this leg rest be able to tuck down further underneath the cardiac chair. This is a tilt table. This is a piece of equipment that's used in therapy where we bring a patient over onto the table and then secure them on with straps or seat belts, and then we start to slowly raise them up. And this is for patients who are very debilitated, who have become unaccustomed to an upright position. Usually the patients are very sick or very intolerant to being in an upright position. So we introduce that in a gradual fashion by having them on this table that slowly raises by degrees to raise them up. It's also useful for patients who have contractures of the ankle. So if someone has either tightness or contracture in the plantar flexed ankle position, this allows them to do some gradual weight bearing and stretch of the ankle joint and the gastrocnemius muscle. So one of the issues with this is that it would be helpful to have two separate foot plates so that the person who maybe has a contracture on one side but not on the other, or is weight bearing, is allowed to be weight bearing on one side but not on the other, the opposite foot plate could be adjusted to accommodate whatever that patient's needs are. So
transferring patients onto the tilt table also poses problems for physical therapists. Just like with the cardiac chair, there's a lot of friction created while moving patients onto the tilt table. However, as you can see here, the tilt table poses an additional challenge during patient transfer due to the knobs on either side of the table. During the transfer, the physical therapist has to have the patient move his or her foot out of the way of the knob or find some other way to avoid hitting it. Physical therapists that work with outpatients have very different needs from inpatient physical therapists. Since their patients are often mobile and can ambulate on their own, they tend to work on re-strengthening injured parts or making mobility easier for patients. Casey Maynard works as a physical therapist at UCD Medical Center. Here he discusses a problem with the rubber bands used to re-strengthen patients who have been injured anywhere from the midsection down. This can include patients with hip, knee, ankle, or spinal cord injuries, as well as stroke patients.
So a lot of times we'll have different patients do different leg exercises and we'll wrap a rubber band around their legs. For the most part it stays in place, but if you're doing like a walking exercise, it kind of rides up the leg, it doesn't give the resistance that we need.
Next, we spoke with Casey about the makeshift crutches that are being used for bilateral amputees.
We use this with a patient. He's a bilateral amputee. He has what we call stubby prosthetics to where he doesn't have his knee, he just has short legs with a large foot on it. So for support, he's not strong enough to support himself with his upper body, so we have to use this kind of forearm pad. However, as you can see, we have this taped to a crutch. So we would need some type of interface, some type of connector, so we would be able to connect one of these forearm holders, or it's called a platform if you're looking for the medical. We made a platform crutch here, but as you can see, it's held together by tape, which isn't exactly safe. So here's the interface how it normally goes. So finding a way to interface this so we're not taping it to the... So find a way, I don't know if it would be something to interface with here or gripping on here, but to attaching to that with these. So I guess it'd be going from a horizontal interface to a more vertical connector.
We will now speak with Pauline Hutton, another physical therapist at UCD Medical Center who is interested in a device that is geared towards helping patients who have disc injuries.
A lot of patients with herniated disc problems are very load sensitive and they can't tolerate sitting or standing. So while they're rehabbing, while they're trying to get better, they're losing their fitness level, their cardiac fitness level. So if we could put them in on a machine that supports their torso and moves their arms and legs, just like a baby crawling, and then be able to adjust it from completely horizontal and gradually lift them up so they can gradually assume more and more load as they're getting better and we can keep their fitness level. That'd be awesome. I haven't seen anything on the market for it. So the closest that I've seen is something like a Versa climber, but again, that's very, very hard to do. It requires a lot of core strength and it's also so loaded. So if we could get something like a Versa climber, but with torso support, starting that is adjustable from horizontal all the way to, to completely vertical, would be huge if we could do something like that.
Respiratory therapists at UCD Medical Center work with patients in pulmonary rehab who have chronic obstructive pulmonary disease, or COPD. They provide encouragement, support, and advice for patients as they work on living with reduced lung function. Many of their patients require oxygen to exercise or to conduct daily activities. The main issues that arise here are related to oxygen tanks, concentrators, and tubing.
I don't know if you guys see the little cards that they pull around their oxygen on. It'd be nice if you guys could come up with a lightweight something for them to take their oxygen with them so it's easy for them to drag along with them. And something, that has wheels, but when they get to their car, sometimes they have a hard time lifting that. Something that they could lift real easy and get it into their car. So like our one patient right now, she's bringing her granddaughter because it's too heavy for her to lift that tank along with the cart. So for somebody like her, if we had something that was real easy to lift, get in the car with the oxygen with no problem, they could be more independent because we don't want to take away anybody's independence. You do have people that cannot quit smoking that need oxygen. So I always advise them, if you're going to light up that cigarette, be sure you shut your oxygen off. And some people forget, and they wind up burning their eyelashes and their eyebrows and some of their hair on their head off, and some people have actually burnt their cannulas into their skin. to where they've had to go to surgery to get the cannulas taken out of their skin. You guys could come up with some type of a chair for balance that has nice, comfortable arms on it, something that could help them with their balance. We don't want people falling and breaking hips, especially our types of patients, because some of these patients, depending on how bad their lung function is, they can't go through surgery. They're stuck. They're stuck with a broken hip.
Oxygen concentrators are often used in lieu of oxygen tanks. They pull in air, which is about 20% oxygen, from a room and run it through 2 cylinders, removing the excess gases. They then deliver the treated air, which can be up to 95% oxygen, to the user.
They make high flow concentrators now, but at 10 liters of oxygen, and that's a lot of oxygen. 10 liters of oxygen, they're only getting 90% oxygen. Maybe you guys can come up with the technology to where they can get 94, 95% oxygen on 10 liters. Why do we lose so much oxygen when it has to go up to that high flow? The technology is there, that you guys can improve on that technology. You know, in the hospital we have devices that where you can dial it in to get a specific amount. What about their concentrators? You know, they should have the availability of these concentrators to be able to deliver that high flow, so that they don't have to use liquid oxygen, because liquid oxygen is very expensive. And the one complaint that they all have is when they're home with their oxygen concentrators, they have to have either a 25-foot or a 50-foot oxygen hose hooked up. So that's another hazard for falling, is their oxygen tubing. So what can we come up with so they don't have that hazard?